And with all the issues, positions we are sorry for the delay. Thank you for your questions, but the problem has been fixed. We can now start on the implementation. This is a good advance. Some American health systems. Which is according to and Priapism. The team of experts which I will have to implement. I will start with this.
Hello, good afternoon, everybody. Thank you for joining us. My name is Dr. Tracy. You may have noticed that I have an accent that you may not be used to hearing. I'm an emergency physician from Australia, working as a seed educator at the Indira Regional Referral Hospital with Must University and Seed Global Health.
My name is Martha Nabinga. I'm an emergency medicine at year 3. I'll be the first president of Kodabu. And thank you for joining me.
We have the health expert Dr. Joseph Wadera online. It's very good in Israel. Are you hearing me?
Yes, good afternoon. I'm happy to be on. My name is Joseph Wadea. I'm a genocide, but also a urology fellow at Mulago National Hospital. Yes, I'm happy to interact with everyone. Thank you for being on.
We have taken the regions and the sequence of expectations. We have some of the few questions that will be displayed on the screen, and you can answer them in the chat box. Number one question is what is the primary symptom of acute urinary syndrome? You have the following objective in food one, which is frequent urination, bacteria, and the difficulties to avoid despite the food bladder. That's one of the questions. The question is what is the primary symptom for acute urinary infections? So it's choose one of them. If the frequent urination, bacteria, inability to breathe, despite the food bladder, and then painful urine. So after that, you can go to our case presentation. Let's see our case presentation from Dr. Nathan Bunga, University of Must. Dr. Nathan, welcome.
Okay, thank you. I hope you can hear me. So I'll be taking you through this case. We shall see what this is about. So we have a patient, NN, who is a 22-year-old, who presents to injection for 48 hours. He's going to suffer from sickle cell. So sorry about that. We received And the 22-year-old male with the main patient of sickle cell anemia who presents to the ED with an eruption for 48 hours. It was severely painful. It started suddenly, and the pain was constant. It was not radiating, and it was not relieved by simple hydration. So on our primary survey, on the assessment, the airway was patent and not at risk. The respiratory rate was 24 cycles per minute, which is slightly elevated. And there was no entry bilaterally with ventricular good sounds and not good sounds. Oxygen saturation and room air was 96%. This gives us a relatively number respiratory exam with the respiratory rate slightly higher, which could lead to pain. And then on the circulation, the extremity one, the capillary pulmonary was 3 seconds. The blood pressure was 108/60 millimeters of mercury, and the pulse rate was 104 beats per minute, which is also slightly elevated. And the assumption we had was probably due to pain. Heart sounds 1 and 2 we had and normal, and there was only slight tachycardia. And the disability, this was 15 out of 15, and we had deficits. And the exposure focused on the system that was mostly affected. So when it was this penis, it was erect, it was swollen, very tender, and it was blue-black in color. There was no major change. And the urinary system, it also stayed.
Symptoms, we had a severely painful erection that had lasted 48 hours. There was no reported allergies to either food or medications. And he was currently not on any medications, but he had a prescription that was about a year ago of tadalafil, 5 milligrams, hydroxyurea of 20 milligrams per kilogram body weight, and imipramine, that was 25 milligrams. The tadalafil was being used to manage his erections, as we shall see from the past medical history. The hydroxyurea was to help him reduce the frequency of the sickle cell crisis, and then the imipramine is an antidepressant. The past medical history, he's known to suffer from led to multiple emergency department visits. to so many facilities, but with almost no relief. And because of the frustration from this, he developed so many suicidal thoughts and attempts, but he did not implement any due to his faith. He had had a severe episode that led to the prescription that I had described above, and from which he had gotten some relief for about a year. So baseline, he had seen so many hematologists, he had seen a psychiatrist, and he was also being seen by a variety of emergency doctors. His last meal was an hour prior to admission, and the event started suddenly. On bedside investigation, we did a hemoglobin estimation, and it was found to be 6.5 grams per deciliter, which coincides with a severe anemia in a sickler. Then our problem list, we had severe penile pain, dehydration, refractory priapism, and severe anemia. So how did we manage? For the severe dehydration, we hydrated him. And for the pain, we gave a penile block and we achieved pain relief. We tried to aspirate with normal saline and also phenylephrine irrigation, but we did not achieve any relief. So we decided to cancel the patient, but also involve urology for further evaluation. We also transfused this patient, and later the patient was disposed of to the urology unit. Thank you.
Okay. Thank you so much, Dr. Martha. Right now, we're going to call you expert on general approach, acute urinary retention and Priapism. We are going to call in Dr. Joseph Wadela, general surgeon and urology fellow at Mugabe. Dr. Wadela. Oh, sorry.
So Dr. Wadea, can you hear us?
Yes, I can hear you very well.
Wonderful. So Dr. Wadea and I are actually going to do a joint presentation together because I think that the emergency department and urology often work very closely hand in hand with these cases. So we're going to comment back and forth about the actual management aspects of urinary retention and priapism. So first of all, we will commence by just talking about the actual definition of acute urinary retention. So this is a painful inability to pass urine and often will have a palpable or a percussible bladder. Now, we have a lovely picture here which shows a large bladder, but it will very much depend on the person's body habitus as to whether you're going to be able to see it quite so clearly. What's your experience of being able to palpate and percuss bladder in most body habituses, Dr. Wadea?
Yeah, most thin people, the bladder will be obviously distended, and then it's palpable. However, if you find obese people, it might not be obvious to your eyes. You rely on the history, the obviously presented pain, and then you may attempt to palpate, but occasionally the groin crease is what you find. And when you go slightly above it and below the umbilicus, you palpate that bladder. One thing you realize that the question would be maybe a disclaimer in this case. is it always painful? Is acute urinary retention always painful? No, sometimes it will not be painful, especially with patients with neurological problems. You have to look for it. That's why we're saying a palpable, a percussible bladder. This is important, especially if the patient has no pain. Yeah.
Absolutely. And I think in these days of ultrasound and slowly we're getting more access to ultrasound, bedside ultrasound in the emergency department is also very useful here. In terms of what causes acute urinary retention, there's a systematic way that you can actually think about it. So I believe that probably the most common thing that comes to people's mind is an obstruction from benign prostatic hypertension. But that's not always the case, is it? You have to have a number of differentials in your mind. And it's going to change as to, your risk is going to change as to whether you are a male or female presenting as well. So you can have obstruction from anatomical causes, whether that be the prostate or other masses such as tumour, which can occur in both males and females. You can have stenosis or critical narrowing of the urinary tract. And then pregnancy, you can have the weight of the fetus itself can cause an anatomical obstruction of the urinary tract and make it difficult to pass urine. Is there anything else you would like to add around that, Dr. Wadea?
Yes, this is very true. This is the commonest way obstruction presents, anatomical obstructions. So you have to consider also that sometimes we tend to think that females don't get obstruction. Females can get obstruction, but the number one cause in female could be neurological problems. So when a female gets obstruction, think about neurological problems. The anatomical causes in females, you have to think again from the meatus all the way to the bladder neck or within the bladder. Strictures, we tend to think strictures only happen in adults, rather in males, they can happen in females. A simple meatostenosis or meatus stricture can cause an obstruction in the female. Tumors that block the bladder neck, like bladder cancer, can block the bladder neck and cause obstruction. The others, you have to think intraluminal, a foreign body, a stone. A patient can pass a stone right from the kidney all the way to the urethra and get stuck there. So intraluminal causes. Others, the clots can block. Yeah, and then of course we have several drugs which can cause anesthesia. So you have to be open-minded, consider how the patient is presenting, the circumstances in which they are presenting, the history. Patients of BPH or prostate enlargement have previous symptoms. So they present with symptoms which could make you think about a risk of obstruction, things like straining, hesitancy, poor stream can tell you that this patient was at risk of obstruction. So you need to take the history with an open mind. But also, since we're dealing with an emergency, you have to be quick. In other words, you're getting this information early enough so that when you have a patient, you have to think beyond the obvious. Thank you. Back to you, Doctor.
We were able to put trauma into every one of those categories there as well. So make sure that in your trauma patient, you are looking for and treating urinary retention, which can come from the actual trauma itself to the bladder, to the urinary tract, to the neurological cause, or the drugs that we're giving people as part of our treatment for the trauma as well. And just to highlight what Dr. Wadea said, like really keep
trauma is very important.
Yeah, please.
Sorry about that. Trauma is very important because you either treat the obstruction or you worsen the obstruction as you try to manage it. trauma can be a cause of acute urinary retention from trauma on the urethra itself or on the lower urinary tract infection, or it can be caused by the injury. For example, if you're from either fracture of the vertebra or cord compression from metastasis. So as you think about trauma, it may be trauma like a fracture in the vertebra causing urinary tract obstruction or retention, or trauma on the urethra blocking the urine flow, or if you have a straddle injury and urethra has been avulsed and there's no flow. So you need to be wide open about which kind of trauma am I dealing with. Is it primarily on the urethra, or is it secondary from the cord?
Absolutely. And I also just wanted to really highlight that neurological component, because we often think of this a bit too late, but it is one of the major presenting complaints that you need to have in your differential cauda equina or trauma to the spinal cord. So thank you for highlighting that. So question is then, who do we catheterize and when do we catheterize? The aim of catheterization obviously is to drain the bladder, but the most important aspect of catheterization is to take the pressure off the kidneys and allow that forward flow through the kidneys through to the bladder, and then obviously to create urine and urinate. So which patients do you identify, Dr. Wadea, as really needing the catheter? Do you have any set criteria that you use?
I think let me start, since we've been talking about trauma. If you identify a patient whom you think has had a urethral injury, for example, by the obvious bladder distension, and then you find blood at the urethra, at the meatus, it's always advised, don't attempt to catheterize because you suspect a straddle injury, and most likely you're going to end up in a blind pouch as you try to catheterize. So usually we say, don't catheterize because you're going to worsen the injury. So wherever you are and you have an injury patient, has a bladder distension, possible urinary obstruction, go for the suprapubic and avoid the catheterization. If you think that according to your injury mechanism, possibly there is no avulsion of this urethra, you may attempt to catheterize, but we discourage it if, for example, you've not had the experience. So if you attempt, we usually inject a lot of KY gel into the urethra and try to catheterize, but I would advise don't. Just go for the easier way, suprapubic, and protect urethra. However, ideally, any patient who has bladder obstruction in pain should have a catheterization, either the normal urethral catheterization or the suprapubic catheterization. So, yeah, catheterized patients who have, but who should get urethra versus who should get a suprapubic. That's where you need to think as a clinician. Yeah. Doctor, I can continue.
That is an excellent point. So just to emphasize, if there is blood at the external urethral meatus in a trauma patient, you're thinking that there is damage that could be made worse by us attempting to catheterize. So think twice before you attempt. And then obviously relief of pain is going to be one of the problems. And also in patients who try to empty their bladder, but are left with some a high amount of urine left in their bladder, even after it has maximally tried to contract, those patients are at high infection risk and may need to have a catheter longer term, but it's not specifically an acute situation. I talked about protecting the kidneys, and this is what can happen as an effect of the obstruction of the kidneys. So on the right side is a normal kidney, or the left side of your screen is a normal kidney. And as that back pressure builds up from the patient unable to pass urine, you get successive worsening of the dilatation or dilation of the urinary pelvis, and that can affect the function of the kidney, which comes to an important component of our investigations, which we will talk about later. So now, as a urologist, Dr. Wadea, what are the most common mistakes you see people making that makes a catheter difficult? And what would you recommend that they try to make their life easier?
Yes, as simple as it sounds, a urethral catheterization can result in very bad complications. And the worst of them is either stricture or a complete avulsion of the urethra. So the aim of the clinician catheterizing is to make sure the catheter reaches the bladder at all times. Because if you don't and you balloon that urethra, you'll injure it. The other thing is the passage of the catheter into the bladder should be smooth all the way. Because when you injure that mucosa along the urethra, you put the patient at risk of developing strictures. So one of the things we usually recommend is that sometimes we say inject a lot of KY. So what I usually do, I pick like 10 mils, a 10 mil syringe, put 10 mils of KY, inject through the urethra so that the path is smooth all the way. And I take an appropriate catheter and make sure it reaches the meatus, all of it. That ensures that it's in. And sometimes I wait to see some fluid coming, some urine. But usually it comes after ballooning the urethra. So it must go all the way. I must balloon it. Clinicians who start ballooning the urethra before it enters put the patient at risk of rupturing that urethra. The other thing is when you put, sorry, I'm forgetting, but when you put that urethra, first be sure that you're in. One of the things is that we press until we see some fluid. If it's a child, we remove the stylet and make sure we see the fluid before we balloon. Then we must make sure it's at the end of the meatus. The lubrication must be clear, must be good enough. The other thing we do, the size of the catheter. If you have a patient who's obstructed, probably from BPH, you need to put that catheter so that it can go via the constricted area of the prostatic urethra. So a soft urethra will not pass there. So pick a big size, 20 plus. It's firm enough to force its way through the enlarged prostate, so it can pass through that small passage which is left. So usually we get patients whose catheterizations have gone bad, and when we check, they tried a small catheter, it got coiled, went hit on the prostate, so they assumed it was in, and actually it didn't go in. A firmer catheter will go in through that constricted part of the prostate into the bladder, and then you do the other maneuvers, like I've said, before you try to balloon. But it can be very devastating when a patient has got an injury from a ruptured urethra or a stricture. Complicated surgeries altogether. Thank you. Doctor, you can go ahead. I see you have some things to explain.
I've heard I've seen some chat around using the lidocaine jelly, and I would absolutely recommend that is a bonus if you can actually use it, if you have access to it. And in fact, I personally will sit there, put the lidocaine jelly in, and then hold the external meatus so it doesn't come running back out again, and allow a couple of minutes for that lidocaine to work. And it can be an awkward couple of minutes while you're standing there holding a gentleman's penis while you're trying to have a conversation, waiting for it to have effect. But it is a couple of minutes well worth spent on making the procedure much easier. So I would also comment on reinforcing that, making sure you get the catheter all the way to the very end of the catheter, the base, to ensure that you're not inflating that balloon anywhere along the tract other than in the bladder itself, because as we don't want to cause problems for our urologist colleagues. Okay, so now I have a couple of videos to demonstrate the procedure. So bearing in mind, these are ideal settings. So you may not have access to all of the equipment, but this is what we should be aiming for as a gold standard. Just on the, I'm very sorry that the video didn't play sound. We're going to skip the next video because it also doesn't have, if sound is not going to work. But there was written instructions following each of those procedures, and I think it highlighted the criticality of maintaining sterility during the procedure as well, because we certainly do not want to introduce infection. And I know this is a very commonly performed procedure, so it's just something to keep in mind. So moving on to investigations, it's important to perform a DRE, a digital rectal exam. So what's your thoughts about performing a DRE on all patients, Dr. Wadea, and getting a PSA for these patients?
Yes, thank you, doctor. If you suspect a patient to be having benign prostate enlargement or possibly cancerous, as part of the assessment is that you do a DRE. Patient should have a DRE, and your aim is to assess the consistency of your prostate. A prostate with cancer usually is nodular, it's bumpy. If it's advanced cancer, you may find many bumps, multiple nodules. The nodulation will be obvious. Sometimes you may feel a few nodules on your prostate. So if you suspect that the patient may have cancer, it's okay, go ahead on the PSA. Your palpation or your catheter will change a little on that PSA if the patient has advanced cancer. If you find it smooth and it's only BPH, just know your catheter will affect and your DRE will affect the results. They will be higher than the normal. So usually, if there's no suspicion of cancer, just put the catheter and wait after 2 weeks when the catheter is out, and then you do a DRE, or rather a PSA. I don't know, doctor, if you want to continue commenting on these results. I wonder whether I'm audible, whether I'm heard. Let me have some feedback.
Thanks, Tracy. And the ultrasound KUB. So in terms of a neurological cause, then CT is going to be your test of choice, especially if the patient has bony mets such as prostate cancer. So which patients would you expect to be admitted, Dr. Wadea?
Yes, the admission here I'm considering is the primary physician. You've seen a patient with chronic obstruction and you want to decide whether you should admit or not. I think one peculiar incidence is where you suspect that this patient initially had chronic urinary retention. This is a patient who has had history suggestive of obstruction. They've had hesitancy, they've had a poor stream, they come to you frail with signs of possible upper tract infections. Upper tract, I mean infection in either the kidney or within the ureter. So they may have symptoms suggestive of pyelonephritis. You do an ultrasound scan and their ureters and pelvis are distended with urine. So it's possible this patient has had chronic obstruction. So if you put your catheter and you relieve them with the obstruction, there's what we call post obstructive diuresis. This patient will continue to form a lot of urine. They lose sodium within the urine because of the chronic obstruction. So if you're able, you can do the electrolytes and you focusing on sodium. And if you find their sodium is low, it means you have to admit them. If you're able, you give them hypertonic saline as you monitor their sodium. You may have to treat their infections. So these are the patients who usually die after we put a catheter. They are elderly, 60 years and over. They've had symptoms of obstruction. They have symptoms suggestive of upper tract infections. You put your catheter and release them. Or you keep them around without monitoring, checking whether they are making too much urine or they have electrolyte imbalances. The next thing you find that the patient died. So those are the patients you shouldn't miss as a first attendant. Yeah. Otherwise, trauma patients will stay admitted or referred. Patients who have had acute obstruction without obvious infection, without history of suggestive of obstruction, you may put a catheter and release them. There are those patients whom you want to try to remove the catheter after some time. You may say, let me admit this patient for a few days, try to remove the catheter and they see. For example, the patient has, maybe you think it's prostate enlargement due to a BPH. It's a small prostate. You may say, let me admit them and see, and then remove. But you need some experience to decide which patient should you remove a catheter or not. Which patient should I admit without obvious complications from obstruction. Yeah, so many times the patient we miss are those who have had chronic obstruction and we release them without treating the infection, without replacing their sodium. Thank you.
And do you put any patients on sort of medication as part of your routine? Or do you recommend that you put people on medication to control BPH?
It's not the immediate treatment you want to give. What you want to do is relieve the obstruction. If you think the patient has obstruction due to a BPH, you may decide to start the drug. But at that time, you putting a catheter to relieve them is good enough, because after all, that's what you want to achieve with the drugs. So there's no need to rush starting the drugs. Put the catheter or put a superpubic catheter, release the obstruction, and leave the patient to the next physician.
Absolutely. And if you've used a sterile technique, you shouldn't need antibiotics.
Yeah.
Okay, so that takes us to the end of the urinary obstruction component. Now, the time critical priapism. All right. So I want to start again with the definition. Priapism is a painful, sustained, and I've got in brackets there 4 hours, unwanted erection. And you wanted the addition of the with or without orgasm. What was your concern with wanting to highlight that this doesn't have to be related to sexual function?
I've had patients who get priapism or prolonged erection without sexual arousal. Patients who have like sickle cells, like the patient doctor presented. So sometimes we think it's after sexual intercourse that you get this prolonged, but there are other predisposing factors to a non-stimulated erection, and then you get a prolonged erection. Yeah.
Absolutely. And on that picture that we have there, I will draw your attention for the audience. It is the corpus cavernosum bilateral. Is tissue, okay? up to 4 hours, it is a reasonably reversible condition. After 4 hours, you start getting death of the smooth muscle that supplies the vasculature, and you can get irreversible damage, such that by 24 hours, 90% of patients will have a degree of irreversibility, and at 48 hours, 100% of patients will have irreversibility of this smooth muscle damage. So time is tissue, okay? The reason being that with loss of smooth muscle and which is responsible for causing erections, then you get long-term erectile dysfunction and impotence. And this can have significant impacts on the patient and the patient's experience. So we're going to talk about two types of priapism. Emergency and non-emergency forms. So the emergency form is where we're going to spend the most of our time. And this is the low flow state that's the ischemic cause, and as opposed to the high flow non-ischemic cause. So next slide, thanks. So just a very brief moment on high flow priapism. Have you actually seen and treated this, Dr. Odeya? High flow?
I haven't treated, but I've seen.
Yeah. So very uncommon, isn't it? And it's usually not painful in the context of trauma. So you've still got oxygenated arterial blood coming into the penis, and you can get outflow of the deoxygenated blood. So you can get this after low flow priapism, but this is not the one that we're most worried about. Okay, so this is the surgical emergency, is low flow priapism. As Dr. Odeya said, the most common presentation here is as a result of sickle cell disease. Idiopathic is your next most common, and there's a number of drugs. We won't go through all of them here, but they are very common drugs that can cause priapism as well as hematological cancers such as leukemias. So this is a painful condition, okay, because those two cavernosum are engorged with blood and it just keeps coming in, but it can't leave the penis, so it's trapped. And one of the key features is that you're more likely to have a soft glands in the high flow priapism, you're less likely to have a soft glands in the low flow priapism. So that, apart from pain, that is another one of the features on examination that can help you tell the difference. So priapism and sickle cell disease is definitely the #1 cause of people presenting with priapism, is my understanding from our conversations. And these people have a really high rate of erectile dysfunction long-term. So it's super important that this is part of the education package that you talk to your sickle cell patients about to prevent those long-term complications. Apart from the fact that people have, with sickle cell disease, have a number of health issues and end up presenting to hospital with pain crises, etc., priapism is certainly associated with a high rate of unrecognised mental health challenges, as mentioned in our case discussion. So the target of treatment is to actually relax the corpus cavernosum and allow that outflow of blood. So I like the memory aid: educate, aspirate, aspirate, irrigate, infiltrate, operate. So that's your plan of attack when treating the priapism. So educate, we've already spoken about. Make your patients aware of the time frame in which they need to present to the emergency department, because this is a treatable disorder, okay? So 4 hours, if you're still having a painful erection at 2 hours, and most definitely by 4 hours, these people should be coming to present to the emergency department. As mentioned, dorsal penile nerve block is going to be your best friend. So a dorsal penile nerve block not only allows the patient to be more comfortable, but it also facilitates the procedure that you're going to perform to drain that corpus cavernosum. So you can see on this picture, the dorsal nerve runs bilaterally either side of the midline on the upper surface of the penis. So that is your target. We have a video following. I might need to narrate over it if our sound is not working. But before we go to the video, sorry, just go back one slide. Just before we go to the video, I typically use approximately 5 mils of a mix of both short-acting and long-acting anaesthetic, and you can dilute that up to 10 mils if you want to give yourself a better field block. But basically, this is a ring block of the penis. It's the same, essentially the same process. And I think we can go to the video now and I can talk over it. So if we can play that. People hearing that? So you'll need to clean the area at the base of the penis to make sure that you have a field that you can work in. You're going to hold the penis and retract it down towards the feet to give yourself some working space. And your target is going to be the lower part of the pubic symphysis. So you're going to have your bevel facing up and you're aiming for that midline area. Insert the tip of the needle just below the skin, put a bleb of local anaesthetic, and then have the needle advance all the way to the bone. Of course, you aspirate every time you inject. Now, pulling your needle back out a little bit, you're going to change your trajectory to 45 degrees either way. So you're going to change 45 degrees to one side, your right side, aspirate and inject 1 to 2 mils. And then you're going to do exactly the same thing in the opposite direction, aspirate and inject 1 to 2 mils. And you might be surprised, the patient will often start to get anaesthesia at this point. But the other thing that I like to do just to ensure that I'm hitting my target is to actually massage that injection of local anaesthetic around to get it to the nerves where you're aiming. This is an incredibly effective technique to provide pain relief to the patient while you do the actual procedure. Next one. Next slide. Thank you. Okay, so the actual procedure itself is injecting at, putting a large bore cannula or a needle in at a 10 and 2 o'clock position into that corpus cavernosum. And you only need to go into the point at which you can aspirate blood. I think the concern is that if you go too far, then you can get hit that central artery, which is what we're trying to avoid. I believe you only need to really aspirate about 20 or up to 40 mils of blood from each side of the corpus cavernosum. And that should, if the patient has presented in a short enough time frame, help to see you'll increase the flaccidity of the penis at that point. You can leave butterflies in if you have access to butterflies. This allows you to both do the next step, but also to have ongoing outflow of the blood in the cavernosum as well. So your next step, so we've tried aspirate, we can try irrigate. So this is why those butterflies are useful. So you flush with 10 to 20 mils of normal saline on either side in an attempt to loosen up those clots. And then you do your aspiration again. And one of the tips I believe you do in your practice, Dr. Adaya, is you actually help encourage outflow by squeezing the penis until you see fresh blood. Is that correct?
Yes, it's very true. We usually squeeze, the attempt is to squeeze out this floated dark blood. But also because we are the last end of emergency, when the patients come to us, we prefer to aspirate from the gland side. Whereas at emergency, the preference is to aspirate from the root of the penis, either the 3 or 9 o'clock positions. We usually tend to aspirate from the dorsum, rather from the glands, avoiding, of course, the dorsal surface, going to the upper outer surface of the glands, right into the corpus. So why we do that? Because many patients will fail on aspiration. And these are the positions where we can do other advanced surgeries to create a connection between the corpus or the corpora and the glands. So when we do that, we can easily use it the same position rather than trying past the root, then go to the gland side. So we usually go to what is most comfortable and safe to do the aspiration and also the injection. Yeah. So for us, this is what actually we call medical management or Priapism, where we aspirate, inject saline, squeeze, and also inject a sympathomimetic, usually phenylephrine, like you saw the presentation of the patient initially. Yeah.
The great tips because, yeah, we often, unfortunately, do see that late presentation. Okay, next slide, thank you. So the infiltrate part of your mnemonic is phenylephrine, and I believe this is increasingly available. So this acts to help with the vasoconstriction to decrease that inflow of blood and allow the outflow, but you must dilute this. The phenylephrine typically comes in 10 milligrams per mil. So if you make it up into 100 mils, then you will get 100 micrograms per mil. And it's only that small dose that you want to inject. So you can inject 1 mil every 5 to 10 minutes, up to a maximum of 5 times both sides to try and help until you get an effect, but don't go further than that. Anything you'd like to add on that, Dr. Wadea? I think you're on mute, sorry.
I believe that's it. Yeah, it's all right.
So you're injecting, this is the same, exactly the same position that you're in when you are draining. So you always stay in the same position. So either from the glands or the 10 and 2 position. But this is why you sort of can leave a drain in situ. Next slide, thanks. So over to you now, Dr. Wadea. This is well and truly beyond my level of expertise. This is when we've tried everything and we're still not getting detumescence. Mute again, sorry.
So we try to create a shunt between this expanded, dilated, engorged corpora cavernosa onto the glands, which is the continuation of the spongiosum. So you're connecting so that blood can flow from the corpora into the glands and continue the backflow. So there are a number of operations. So I want to talk to that medical officer who thinks they can do a shunt. If you think you can do a shunt, or you've seen someone do it, or you've gotten involved in where it's done, I prefer you stop at this stage, which is called the winter shunt, where we use a cannula needle. Usually the gray cannula, the 16 gauge, we pick that needle out. And you see this outer part of the glands. That's where we take it all the way up to the glands. So you have to palpate all the way up to the corpora. So you have to palpate the corpus. You'll feel that tip end of the corpus. Then you take your needle all the way through and you connect. So you're trying to connect that, those two. Usually it's a small connection and it has a high failure rate. If it works, this is the way it works. You're seeing that blood is now connecting to flow in the spongiosum. If you fail, you might have to stop here unless you've been trained to do other shunts like the T shunt. Now, in our setting, many of the patients come late. So ideally, they have 90% or 100% are going to have electoral dysfunction. So sometimes ideally, the management is that these patients should get an implant immediately, but we don't have this available. So many of our patients, like you've seen the presented patient, the patient already had previous episodes of priapism and had got erectile dysfunction. So he had even got psychological problems because of the erectile dysfunction he had got from the previous episodes. So this is the candidate for an implant. And I assume, considering the stigma associated with priapism, which contributes to their late presentation, this patient must have presented already 4 hours late at their first presentation. So they were a candidate for a penile implant at that time. Sometimes we go for implant straight away. Usually they go for an implant straight away if you fail to achieve the tumescence. The tumescence is when the erection goes down. If you can't achieve it, we'll go for an implant immediately, which we can control. Yeah, so for a medical officer who can do this shunt, you may have to stop here. If it fails, you quickly call in the surgeons to do the other shunts. Yeah. Thank you. Stop.
Aspirate, aspirate, irrigate, infiltrate, and if all that fails, operate. Thank you. Okay.
erectile dysfunction in case of no intervention done on the patient? That's question one. Then another question is, so another question is, another question says, when you squeeze the peanuts, do the clots come out from the needle puncture?
Yes. Is sound working now? Yeah. So did you want to take that question, Dr. Wadaya?
Yes, the aim is for the blood to come out through that puncture. But as you can imagine, the needle puncture, 19 gauge, the largest you can use on the shoot of the penis, it might be small for someone who has stayed over 4 hours. We have patients who come even after days. We had a patient who came after 5 days. So you don't expect a lot of clot to go through that puncture. However, if a patient comes early, there's a high chance that the blood is not yet clotted and can come out to relieve pressure within the corpora. So you expect blood to come through there. If it doesn't, don't be surprised, considering the way our patients present.
Then another question is from Sembus. John is asking, where do we expect to see fresh blood while you're squeezing? Is it coming from aspiration spot, or you first keep the aspiration needle in the situ?
You keep the needle in situ because you inject the saline, then you compress. Keep the needle in situ because you're going to compress and then compress. Sometimes you aspirate. So it's a combination. You're pressing, you're aspirating, you're injecting.
Then another question is, what do you use to put local anesthesia into the urethra?
Yeah, I think doctor can answer that.
So you can use, there's some specific syringes that you can use that have a very narrow end, almost like a one of those 50 ml catheter tip syringes, but on a much smaller scale. If you do not have access to that, then you can take the plastic tubing off a 16 or a 14 gauge cannula and attach it to the end of a Luer lock syringe and use that to infiltrate into the urethra. Not the needle part, just the plastic part.
So any question? Any question? Okay, I think I can't see anyone raising the arm in the chat. Is there anyone who wants to ask any question, please? Any question, raise your hand and we'll give you the platform. You ask the experts. Yes. Let's see again.
Oh, yes, there are 3 hands. I have a hand from Thomas Ongom.
Oh, let's see it here.
Yes, please. Thank you for the wonderful presentation. What is the pathophysiology of post-obstructive diuresis?
So I can take that. A post-obstructive diuresis is when you basically had a high pressure situation, which reverses the normal pressure gradient from the nephrons across into the collecting ducts and out into your urinary pelvis. So you have no forward flow, and you get that negative feedback on the nephrons, and you actually get some activation of the ADH system as well. And then when you suddenly relieve that, you get an almost immediate reversal of that pressure flow, and you get the nephrons are now working overtime and are overstimulated and end up producing large amounts of urine. And then all the resultant sodium losses as discussed by Dr. Wadea.
Okay, let me allow a question from Herbert Mutumba.
Yes, good afternoon, everyone. Thank you so much for the presentation. I need to understand something about sildenafil. I got some of they use it to manage the priapism, but at least I know it's one of the drugs that cause prolonged erection. So how does it work? How would it help someone who is already having priapism? Thank you.
I think that's one for you, Dr. Wadaya, because we use sildenafil to help relax the smooth muscles to increase.
So the way the drug works is to cause of blood in those veins. So if you have an overdose, or one of the side effects is a prolonged erection, so the patient will present with priapism. Briefly, that's it. You have prolonged relaxation of the smooth muscle of the veins. There's pooling of blood, which of course contributes to the erection, and then you have a prolonged erection in that case. So briefly, that's it. Without going into the pathochemistry.
I wanted, isn't it counterproductive? Is there maybe a specific dose that we can use
Of
the sildenafil? Is there a specific dose we can use? Because I see it as it becomes counterproductive. What we are fighting is the pooling of blood, and yet it causes that.
Yeah, it's one of its side effects. Usually we use 5 to 10 milligrams. So, the patient can choose to take it anytime. Can choose to take more, depending on how they want to use it. You've had patients who abuse the drug. Yeah, so.
So, any other question? Achai, Alfred.
Yes, good afternoon, everyone. I'm just trying to ask the doctor if I'm trying to see the patient as they come with priapism, they are in severe pain due to that engorgement in the veins. I was trying to ask this. Before I try to aspirate the engorged blood from the vein, do I need first to block the pudendal nerves on both sides, the 3 and 11, before I proceed? Because I'm trying to look at, it's more painful. And then 2, the issue of infiltrating with the normal saline. I'm trying to look at it in this way. Since the inside the vessel already is engorged with more blood, now if I'm trying to again add more of the normal saline in the process of making it more dilute, considering these cyclers with those aggregates of cells, don't you think it will again cause more pain instead? Thank you.
I don't think you need to. Thank you very much. That's a good question. I think pain's a significant issue, which is why I really think that the use of the dorsal penile nerve block is a simple technique that has very low complication rates. So I think I would advocate for you to, again, have a look at using that, because it is highly effective, and as you quite rightly said, will make all things that we do subsequently tolerable. Over to you, Dr. Wadea.
Yes, the dorsal nerve. Thank you, Mr. Alfred. The dorsal nerve block is adequate. You don't need to block the pudendal nerve, because its supply is the lower half of the scrotum, a bit below the root of the penis. So the dorsal nerve block is enough. And then the concern of whether you're adding more saline, how will it get out? That's why we first aspirate. You aspirate, then you put the saline. We're putting the saline to try and break the breakable clot, try to make it more liquid for aspiration. So in addition, of course, you have the squeezing. When you squeeze, of course, the saline will come out in case it hasn't broken any clot. Yeah, it's usually, you'll see some results. If they are not sufficient, it's because of the pathology, the prolonged presentation with a thick clot which can't come out, even with just simple aspiration and injection. Don't be frustrated if it doesn't work. Considering our presentations, release the patient as quickly as possible, or if you're in a center where surgeons are available, you call them in quickly to do the other things.
Okay, thank you.
Patrick. Patrick Wani. Okay. Next part, Wani Patrick. On mute then.
Yes, good afternoon. So I would like just some clarification about the o'clock that we use while aspirating. I saw on the documentation that the dorsal cavernosum aspiration we use now o'clock 2 and 10. And then when we are using the gland site, I've heard of 3 and 9. So I just need some, why are they not in the same o'clock since we have the same orientation? And then number 2 is when you use the aspiration through the gland site, where do you connect that cannula that you are using for aspirating? Do you connect it into some equipment that maybe can be pulling, or you just aspirate and later you can refer the patient with it in situ? Thank you.
Thank you, Mr. Wani. Okay, the initial 2 and 10 were injections at the root of the penis for the nerve block, because that's where the 2 nerves are located. That's not aspiration. The aspiration is either the root of the penis at the 3 and 9 o'clock, either 3 or 9 o'clock, or the glands. I think we needed a clarification. So having done the block at the 2 and 10, you move to the aspiration, where you use a large gauge needle. 19 is the preferred. 19 is usually that needle on the blood transfusion set. It's big enough. So that one you put at the 3 or 9 o'clock. You can aspirate with a syringe, like a 20 ml syringe, and aspirate. On the glands, still, if you don't have the skill of aspiration of the glands, don't do it, because it's one area where you can end up into the dorsum of the penis and injure the dorsal veins. However, your aim, if you've ever palpated an erect penis, if you're a male here, you should palpate your penis. You realize that actually the glans is not erect, it's not hard. Rather, the inner part, which is the corpus, the one which is firm. And if you palpate carefully at the glans, you feel a pointed part of the corpus. So the aim is to go through that part by the glans. So you put your needle through the glans into that area, the pointed part of the corpus. So you're making a connection. So when you put that needle, now aspirate. The winters which I showed you, when you use that needle and remove it, in other words, you'll have made a connection between the erect corpus and the non-erect glans, which is part of the spongiosa. So now the other thing is, don't connect to any machine to aspirate. There's no need. Use your manual aspiration using a spoon, it will work. If it's not, the surgeon can do more things.
And I think thank you for that, Dr. Wadaya. I think I'd just like to add that the reason why the books are emphasizing, somewhere between the 9 and 10 o'clock or the 2 and 3 o'clock position for the aspiration is that you're well away from the neurovascular bundle that runs down the midline on the surface of the penis. And then on the underside, you're well away from the urethra and the corpus spongiosum. So it's almost like the triangle of safety when you're putting in a chest tube.
Recording in progress.
Okay, let me welcome. I see Achai Alfred is still raising the arm.
Yes. Thank you once again. I was trying to ask Doctor, in his experience on managing this patient with priapism, which category of patient are more commonly? Because when I try to look at the cyclers, yes, we have, like us here, we have so many of them, but the cases from cyclers are few. Is it because cyclers who reach more than 18 and above, they are few? Because we have not got many cases among them. The people who sometimes comes are even different from the people who are cyclers. So I want at least some information from him, statistics, which people are most common. Is it the people who abuse these drugs for their erection, their weak erection? Are they the most common people? Okay, thank you.
Okay, thank you, Doctor. Thank you, Mr. Alfred. One way we should look at priapism in cyclers is it's like any other veno-occlusive crisis or vesiculo-occlusive crisis. The crises in cyclers are caused by blockage of blood vessels by the sickled cells. The difference is that this time in the penis, the vessels which are blocked by the sickled vessels are the venous outlet. So the blood is retained in the penis. So you shouldn't look at it as any other presentation. It's a crisis. It's a vascular occlusive crisis in a cycler. And initially, your medical management, as you try to manage, of course, like you saw that patient had dehydration, so manage the fluids. If they need a blood transfusion, give them, but don't get stuck there on the medical management. Just know that most of the time, the medical management will be frustrating. So I advise that everyone here who gets a sickler with priapism, don't retain a patient as you try to give the medical treatment. Give it and move the patient quickly. Initially, there was a thought that maybe the priapism would go down on blood transfusion, on fluids. So there was no point where the surgeon would come in, and most patients will be retained in the medical management. So for us here, we should know that many times our patient they'll come in late, and it will be frustrating to retain a patient. So start your medical management and move. Who comes to us with this crisis? We don't have the statistics in Uganda. Your experience is the same. Before I moved into surgery, I would rarely see patients with priapism. The explanations could be possibly, like you said, the patients are a bit older, teenagers, 10 years, 11, 12, like this one is 22. So there is a lot of stigma that they will not even quickly move into the general clinic. Otherwise, if it's a young child of 6 years, the parent will bring them in and present to them. So it's common presentation in the emergency setting, surgical emergency setting, the patients come. Why they don't come to our general clinics? It's possible because of they can't come to there are other explanations. We don't have data to tell us why they don't come immediately. But just know, Mr. Alfred, if you went to an emergency setting, the patients come. Yeah, they come to you.
Yes, doctor. Again, thank you for that. And then there was one day I managed one. So this was about 14-year-old boy anyway, similar with that priapism. Yes, that was at a boy. I could not now remember well if it was a sickler, but what I did, yes, we aspirated the blood, and approximately just about 10 mils, and the child improved. Actually, approximately 10 mils. So now I wanted to ask, in also your experience as you manage them, do you normally in aspiration of the blood, do you get more than what I got? Thank you.
You can actually get more, depending on the duration and depending whether you achieve what we call the tumescence. Because once you achieve the tumescence, no matter how much you've removed, there's no need. You stop there. The erection is down, the blood is pink, there's no need to continue. Yeah, but you can get more than that.
Okay, thank you.
Okay. Another question is coming from the chat, is asking, what is the role of muscle relaxants in this condition? This is from Henry Huntington.
Dr. Tracy,
Yeah, I like where you're coming from. You're thinking that if it's a smooth muscle problem, will muscle relaxants help? Unfortunately, no. This is a local problem, and it's the smooth muscle vasculature of the penis that we're targeting. We don't want to have the whole of the body affected. Dr. Wadea and I were having a conversation though about some case reports that have happened in the literature for people with acute onset of priapism, where they can, perhaps try and shunt the blood by doing exercise, but that's to create a different pool for the blood to go into. But it is not recommended that you use that in an attempt to delay people from coming to the to seek treatment. They need to come and get treatment. So no to muscle relaxants, yes to education, and get to care early.
The last question is from Sembus John in the chat, is saying, what's the best anesthesia in children? Is giving option.
To allow you to get the block in the first place, really. Once they're pain-free, they'll be a lot more compliant. What's your experience, Dr. Wadea?
Sorry, I lost you. Somehow I lost sound.
Sorry, I was just asking, what is your experience in children? Do they generally need a general anesthetic, or are you able to get away with a procedural sedation to make them compliant enough for the procedure?
Yeah, children will usually need a sedation. We've had usually that trouble. You have a 10-year-old, 13, you can't tell if they can stand a block, but at that time the pain is too much that they can stand the block. Sometimes you may need sedation and you need an anesthetist around to sedate a younger child. But you always have those patients where you're not sure, can they stand a local anesthetic or not. But if they are young, call for anesthesia to give you a sedation.
So right now we are going to have like the answer. I'm going to read the closing remarks. The answers to the question we had in the pretest. We are going to get the answers from the question, or we are going to ask the question again, then we get the answers. What is it? The question again.
I think people are busy answering the post-test.
Okay. While the people are answering the questions, we are going to have closing remarks. I'll start with Dr. Wadea.
Yes, thank you so much for giving me this opportunity to share something. I want to thank SEED, the Emergency Medicine Commission at the Ministry, all the presenters, Dr. Nadunga, Dr. Tracy, thank you so much. Our beloved congregation, I'm so thrilled to see this big congregation coming to hear this, and we hope that we've impacted something in your practice. Thank you for all the work you do, for the patients you reach, the ones you help, the ones you choose to refer. We really thank you for the work you do. Yeah, I'm so happy for this presentation. Thank you. I know we've had some problems, but I believe there's some transfer of knowledge which you've achieved.
Dr. Martha Nadunga, your closing remarks.
Thank you, everyone, for attending this session, and for the organizing team for choosing such a good topic, and also getting on board very, very knowledgeable specialists and experts to try and break down this as much as they have. Thank you so much, and enjoy your weekend.
Thank you so much, Dr. Martha. Dr. Tracy, your closing remarks.
Thank you, everyone, for inviting me to share this, and I appreciate all of the patients. I hope that you've been able to walk away from this session with just 1 or 2 pieces of extra knowledge that you didn't have when you started. And it has been a wonderful opportunity for me to collaborate with my surgical colleague and the team here that has put together this session. So very much appreciate your time and the fabulous questions. Thank you.
Before I can give my closing remarks, the question was, what is the, okay. The question was, what is the primary symptom of acute urinary retention? And I think the most people have chosen is the inability to void despite a full bladder. And then the second question was, which diagnostic tool commonly assesses bladder volume in acute? Which, okay. So the other one is based on the echo session today, where the objectives met. This is like an assessment. We are going to go through this. Make sure you answer this question. Then my closing remarks, you guys, thank you for being patient with us. We had some technological problems today, which I think will be sorted, and next time we are not going to go through the same. I remain Donato Mugumya. God bless you. Guys, you can turn on videos and you take screenshots. Technology issues.
Shakira. Call video right.
People turn on your videos, I will need to take a screenshot here. We also want to see you. Alvin Mark, I'm seeing you. John Welle, Lamek Nabis. I'm seeing Henry Huntington, I can see you. Dr. Kamara, you know something. Abakari. Yeah. Muhumza. Thank you guys. Have a good evening and a nice weekend.
Thank you.
Yes, thank you very
much.
Thank you very much. Have a good weekend. Thank you very much for a wonderful session.
Thank you.